Good afternoon, and thank you for joining our webinar today. Our theme today is strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. Our topic today is Community Complex Care Response Team to improve geriatric public health outcomes. This is today's agenda. Our presenters today are Carolyn Pickering, Assistant Professor of the School of Nursing, University of Texas Health Science Center, San Antonio; Christopher Maxwell, from the School of Criminal Justice and College of Social Science at Michigan State University; and Fuad Abujarad, Assistant Professor of Emergency Medicine at Yale University. So go ahead, and would you all like to start?
Sure, that was an easy introduction. Hi, so this is Carolyn Pickering speaking. Thank you all for joining us this afternoon. So we're going to give you a progress report, a research and progress report on our project, and talk to you about the impact of service alignment and integration on geriatric public health outcomes delivered by a community complex care response team approach. And we abbreviate that as CCRT as we go through the slides because that's a mouthful. So to tell you about the program overview and the general service model that we're testing. Come on, slide. So the community that we've been working with is Calhoun County, Michigan, which is in south central lower Michigan for anyone who's not familiar. It's home to Kellogg's, with our Tony the Tiger there. There's about 140,000 residents in that county with a mix of urban and rural geographies. The largest city in Calhoun County is the city of Battle Creek. So how this program got started was folks in Calhoun County worked together to get an award from the Office of Violence Against Women to form the Elder Abuse Prevention Network. And as part of that, they were doing some community capacity building to identify ways of strengthening responses to abuse and neglect in the city as well as the whole county. From that, they identified a really important need was the ability to share information between health and human service agencies. And so from that, a very key important outcome of this was that they developed a uniform consent form. And this uniform consent form has been the platform for everything that we've done since then. And the uniform consent form allows for sharing of data and information between agencies, between sectors, follows all the standard consent language, HIPAA language, mental health disclosures, but the community and the group was able to work together to get it all in one form, because as we'll tell you later, tracking down vulnerable older adults to get signatures for things can be really challenging. And so having this form has been really important, both pragmatically speaking from that reason, but also because it now lets all these agencies work together. So now that we had that key piece done, the other outcome from that was the development of an informal coordinated community response team. In 2015, with funding from Hartford, the group was able to work on a more formalized community response model protocol and able to do multi-sector coordinated case management. With that, we developed and piloted some technology in the form of an electronic case management system. And we also then worked that to get an actual pilot test of that uniform consent form going. We also then, in the course of that, expanded our stakeholders, and that's how we became the C3RT as we folded in additional members of the community to be active participants. So currently, we're doing a field RCT to test this model as a primary prevention protocol for preventing elder abuse and neglect and a few other geriatric public health outcomes. We have been able to build on the success of this model, and once this project is, or based on what we learned in this project, particularly one of our outcomes having to do with the technology piece, we're going to be able to continue to build on this with an award from the Office of Victims of Crime to create technology improvements to improve our referral system of connecting victims to services. So our program's goal and the aim is really to impact the social determinants that contribute to vulnerabilities of community-dwelling older adults. The model itself is a comprehensive, multi-sector service model that is community-driven and delivers a coordinated case management approach. And so within that, what we really mean is that this team works together to identify and align services across the different agencies and across the different sectors in order to primarily address older adults' capacities for self-care. So some key innovative dimensions of this program is that the service partners get to share in the decision-making. So we've been breaking down some silos in this. It's guided by the principles of the warm transfer and person-centered care. And for anyone not familiar with the warm transfer idea, it's about a referral method where it's not just getting the information to the person. It is delivering the idea of like a body, that warm transfer. So we have the person in the office. I'm going to connect you while you're here to this other person, give the right information to the right person for the right reason at the right time. That way you really know that that referral you're making gets connected to that agency you're sending them to. It's also based on a more data sharing philosophy. And as I mentioned, we have that really important consent, and we have all sorts of business agreements in place to allow us to do that. But it really follows a open data sharing philosophy to allow them to do this. And it's also importantly enabled by technology to be able to share the data and manage the communication between the partners in a secure way. So our Community Complex Response Team, or C3RT, consists of a few core development partners. So these are the partners who've been really driving the train through these various awards and development phases, which includes CareWell Services of Southwest, which is the Michigan Region 3B Area Agency on Aging. They actually are I guess you could say, they're a program manager or really our project quarterback. We've got fantastic partners there who keep the day-to-day operations going of the program. We also include Elder Law of Michigan, Michigan State University College of Nursing, their Biomedical Research Informatics Corps, who's helped with the technology, the College of Social Science and School of Criminal Justice, the UT Health Science Center, and Yale University School of Medicine. So how our C3RT or our program model works in actual practice. This slide, we have another slide coming up to tell you how the case flow works for an evaluation purpose. But as far as a program delivery purpose, it basically consists of two parts. On the left-hand side, you see our referral partners, and so they're tasked with identifying vulnerable older adults who may benefit from connections to community services. And so this includes our local police, the local EMS service provider, the local emergency department, and then the inpatient discharge planners as well. And so we have a system set up by which they can make referrals over to the C3RT, which is our high-risk case management partners. Our area agency on aging receives these referrals and starts the intake process, and then is able to share the information with our other community partners who are currently part of the model, though we know that this is by no means the end point, that we want everybody in the community to be part of this, and most of our community members do want to be folded in here on this right-hand side. But for now, it includes a group that does the geriatric evaluation and management, so these are things like the dementia screening services, as well as prevention, health promotion focused classes, the local federally qualified healthcare center, the local PACE organization, and the local waiver organization. And so together they're able to share information about the client, to also discuss services they're trying to enroll in, simple logistical things like, I can't find this client, has anybody seen them, do you have an alternate phone number? So all sorts of information gets shared through this custom electronic record we built. So together they're able to plan for and deliver over 60 multi-sector services, which is enabled by that information exchange, that loop-back communication, so we know a referral wasn't just received, but we know whether or not it was implemented and why. And so that allows for that shared decision-making. So what happens, oops, come on, slide. So what happens on the initial client contact once our partners at the Area Agency on Aging receive the referral? And that initial client contact, they explain why they got the referral, the purpose of the program, and our program manager listens to those initial concerns of the older adult who was referred. She also has access to a few other data management systems from the local healthcare system, so she's able to have a little bit of an idea of things they may or may not already be connected to, as well as some eligibility criteria for services that might be available to them in this community. And so she likes to say, she told us her phrase when she meets with these clients is that I am here to bring joy to your life. And so she takes a person-centered approach in listening to their concerns, the older adults' concerns, what they think is going on with their life, what they think the problems are that they would like to get addressed. So taking all that information into consideration, including what she knows from her other data management systems, she's able to start to think of a best approach forward and how to meet their goals and needs. On the second contact, she usually does a home visit, and we've learned these are extremely important. But the client can refuse and choose to do things over the phone, though most people don't refuse. She explains again her approach and philosophy, that idea that she's there to bring joy to their lives and reduce their burdens and worries. And then she uses that person-centered, compassionate listening to build rapport with the client. And when she leaves this meeting, she has a what she calls the next step sheet, which are the 3 areas that the older adult has identified as being the important goals to work towards. And that helps inform them the referral making and the service planning she does with the other partners. So now I'm going to pass it off to Chris.
Good afternoon, everybody. This is Chris Maxwell from Michigan State University, and I'm going to just go through some preliminary sort of process and outcomes. We don't have outcome data yet, but I'll just talk a little bit about what the outcomes will be as part of the evaluation. As Carolyn noted earlier, we have a case flow process that goes on. This is similar to the chart that you saw earlier, but it demonstrates where the random assignment takes place in the study. And so step 1 is, as you heard before, about the referrals. They come in from our community partner agencies. They go to step 2, which is AAA, and in AAA our intake person, our coordinator, screens, does the intake, fills out the forms with the person on the phone, and then does the sort of a complex consent process in terms of first getting them to consent to participate in the program, explains to them about the common data sharing agreement that they'll use to help facilitate connectivities between the different agencies. And if they agree to that, then she invites them, ideally at that point she would invite them to participate in the evaluation that Michigan State is leading. And we have an agreement with the IRB to allow for a verbal consent to use existing data. And that's because we're not collecting any additional data to do the evaluation component than what's not already collected by the intake process and beyond the other systems of care that are set up in the community. So we do not have a separate research component to collect data for the project. So we're just asking if we can use their existing data for the evaluation. And at that point, then the clients, if they consent, are then randomly, we have a random assignment process in place. The intake person at that point then will know what treatment group they will be assigned to. And at that point, the protocols for what she does at the intake process then change course depending on which treatment. And half the cases should be assigned to the CCRT team, or half of them to the AAA standard protocol for responding to referrals. And Carolyn can, if people have questions about what the standard protocol is, Carolyn can ask some questions about that. And then at this point, that the experiment has begun in terms of evaluating the process and outcome of the treatment. So the key process and outcome measures we've developed in collaboration with our local partners is the first question is does the CCR team deliver more services and connect the person, not themselves deliver, but do they connect themselves to more service provisions, both for the short term to stabilize the person in the community, and then long term to be able to allow the person to maintain or manage their living in the community. And so we have three key process measures up on the screen to show you that these are the things we're going to measure to see whether the CCRT team is delivering. In terms of outcomes, we have 4 key outcomes that we're going to look at for the long term. The first one is the implementation of this program, the assignment of them to the CCRT team, delaying future contacts with the Adult Protective Service Agency. So we have a data sharing agreement with the Michigan APS system to allow us to access the records of people who we provide them their names to see, and we're going to get some pretty detailed information from them to know whether the number of contacts and the time of the first contact post-implementation. So we'll be able to do a survival model for time to failure. The same is true with law enforcement. We're working with the law enforcement agency to be able to identify whether there has been more incidents or calls for service to the residents of the client. And the same is true for the EMS. And finally, one of the key outcomes is whether we've delayed or have fewer return visits to the ED. So those are 4, does it prevent EMS, law enforcement, adult protective services, and the ED visits. So while we piloted the parts of the process with our local partner agencies, at this point we have already identified some challenges. One of them is we're not getting the expected number of law enforcement and EMS referrals that we had expected from what they had told us that they were going to be able to provide. We've not been able to get the level of activity that they had anticipated. We've been trying to deal with that program challenge in a number of different ways. With the help of Robert Wood, we created some reminder posters to hang up in their break rooms and other places, in their squad rooms, and to remind them about the importance of doing the referrals each and every time they come into contact with someone who's eligible for the study. We've met with the command staff again to reiterate the importance of this study and the evaluation and the program itself. And we've been allowed to retrain the patrol officers in terms of reminding them about the protocol, how to do the referrals, and we've done that through their roll call. And so we've been trying to take steps along the way to encourage them to participate more fully in the implementation. And so at this point, nearly all of our referrals are coming from the hospital. In fact, on the opposite side, we're getting many more referrals from the hospital than what they had expected and we had anticipated. So in the aggregate, our numbers are at about the right number of cases that we had expected to get at this point in the process. It's just the mix of them are much different than what we had anticipated. And one of the problems that we've discovered is that the referrals from the hospitals clients are much more sicker, and I'm not sure if that's a technical term, than we had anticipated from the pilot data. And this has impacted our intake process at the very beginning of the study, where we assess the clients. And because they are coming from the hospital setting, they are needing to be sort of reestablished in the community. They're not already living in their homes, which would have been the case with the police, but they're maybe returning to their home or returning to someone else's home. from the hospital. So we're spending more time on the CCR3 side of establishing the person back in the community than we anticipated. And then once stable, that we're able to assess the client for their long-term services. So we've sort of introduced an intermediate step so that the long-term program can be successful. We need to establish them back into the community. So this mix of clients has impacted the evaluation. Because many times the clients are sick or than we expected when our intake person contacts them on the phone, she does not, and we don't think it's appropriate at that point to seek their verbal consent to participate in the evaluation. Many clients are not receptive to hearing about an evaluation when they're in crisis, and so we don't anticipate or don't expect our intake person to go through the consent process at that time. And so that has caused us to adjust the intake process in terms of the evaluation. And so we are now, evaluation part of the team is more involved in getting the consent than we had initially anticipated. So now we're following up with the control group. We're the ones doing the follow-up to get the consent through phone calls and letters, and trying to contact them in whatever way we can, including we've begun to go door to door to follow up with the clients to assess their willingness to allow us to use their data for the evaluation. So this has added in particularly an extra burden on the entire project, as now we're making weekly door to door contact with at least half the clients. So to date, our enrollment is going as we expected in terms of aggregate numbers. We're about 10 months into what we had anticipated was going to be a 24-month enrollment period. We're probably not going to have 24 months because we were delayed with the technology implementation issues. But we're going to have probably another 8 to 10 months of enrollment. We're going to have, and so our expectation, we're going to get to about 250 referred clients. Right now we have 105 that are actually enrolled and randomly assigned to one of the two treatment groups. As you can see on the screen, there are a couple reasons why some of the referred clients are not participating. Some of the cases is because the referral, we haven't been able to contact the client because the hospital has referred them to us, but we have not been able to find them. Some of them haven't been eligible for various reasons, including the fact that they were referred to us while they were still in the hospital, and so they actually haven't left the hospital, so they're not yet eligible. They may become eligible at some point. And then some of them aren't simply interested in the project. In terms of how it's impacted our evaluation, 24 of the 105, or about 25%, slightly, have just verbally declined our use of their data. 19 of them initially declined on the phone with our intake person, and then 5 later declined when we needed to follow up to get the signed HIPAA form. At this point, we have 30 HIPAA consent forms that have been returned to us. Now, HIPAA forms are not necessary to use all their data, but we needed to get the HIPAA forms signed to be able to access their hospital ED data. So it impacts a part of the evaluation. So to date, we have 49 people randomly assigned to the C3RT group and 56 assigned to the INR group. The difference here is basically by chance still, because the enrollment is a random process, and it takes place after the person has consented to participate in the program. At this point, when they agree to participate, they don't know whether they're going to be in the normal treatment group or the high-risk treatment group, and so their decision to participate isn't based upon which group they've been assigned to. And now we're going to switch back to Carolyn, who will talk about a different part of the project, which is the stakeholder interviews.
Yes. So the third objective of our project was to look at, we flipped. Was to look at the implementation and translational issues of data sharing across the health, human, and civil service sectors, which, as you can probably just anticipate, there's several. But we were trying to find what these were and problem solve them so we can ensure generalizability and successful dissemination of this model protocol. And so the outcome of this, this last objective of the project was to essentially create a blueprint of how the model, best practices for how this model works in our community, as far as both logistically from program roles to technology-wise, data sharing-wise, and to also think about which aspects we believe are essential and which are the ones that could be adapted in future replications to be more community-specific. So with this, we did a series of community forums, and we had 15 of the local multi-sector services agencies participate, ranging all the way from city groups, our coordinating, the City Coordinating Council, the Adult Protective Services, Fire, EMS, Meals on Wheels. We got a really nice range of participants in this. So what we did was 2 rounds of community forums. Our first round was focusing on, we called it Magic Wand Day. But before we even got to the discussion, we started with a planning survey. And so we found this article, this reference I have up here, when we were planning for this, and they provided a survey in there. They were actually trying to increase interagency collaboration in the community for youth with behavioral problems, but their questions were fantastic and very easily flipped to aging services. And so we gave this out partially to let us know where we stood and also to provide some discussion points in the meeting. And so some of the examples of this planning survey include things like the system of service delivery in this community creates opportunities for joint planning across agencies that serve older adults, which leads to a unified direction in planning activities. And then the respondents would have a Likert scale for this. This is another important one in terms of what we were doing. This other example about if one agency contacts an older adult, the service needs in other areas are usually communicated to that appropriate agency. So after we did the planning survey, we then started our group discussion, which we called Magic Wand Day, as I mentioned. And the 3 main foci for these round 1 forums, we're talking about systems engagement, just what type of coordination is required, and do we have any sort of informal or formal system going on in the community beyond what we're currently doing? What the buy-in is to better coordination. So what were the benefits and values of interagency coordination, both on like an individual staff member level? How could this benefit your job? How can it benefit your agency? How can it benefit your clients? And then we talked about what the ideal system was, and we kept reinforcing this idea of magic wand. There are no barriers. If you can do anything you want, how would this system be running for you? So we did these were a series of small groups. We didn't have all 15 people at the same time. They ranged from 2-person to 6-person groups, and we ran a few of them over a course of a week. And so what we found was with that planning survey, there was no agreement on a majority of the survey items, which I thought was a little surprising because we've been working in the community so long. I thought for sure I would have answered I agree. But so it was interesting to see that the agency members did not have any consensus. So for example, one of the items, regardless of the agency that first makes contact with an older adult in need, clients are usually referred to the appropriate service provider without unnecessary delay. And so it's pretty, a lot of people said no, but we also had a lot of people who answered not sures. A big chunk of the responses on all 10 of the items were actually not sures. There were two items that the community agreed on, although one of them I would say just barely at 53%, but it was the closest we got, which was that the community did have a system of services for older adults that historically has been well coordinated and shown evidence of collaboration. So that was good because that's what we've been working with the group for a while, so we're glad that everyone felt that historically they worked together well. The other one, and probably the most important one that everyone agreed on, was that their agency would be willing to share limited data and information about their clients for the purpose of coordinating services. There's only one person who said she wasn't sure, but this was great because we had, like I said, out of the 15 partners, 13 of them were people who were currently part of our high-risk team. So to see that so many agencies in the community would be willing to work to get around or accommodate data sharing rules to be part of this was fantastic. What we learned from the discussions was that everyone did value working together and sharing this information for the sake of helping older adults. They also actually agreed that this sort of a model would be useful for several other client populations in the community, such as homeless and mental, working with folks with substance abuse and mental illness issues. Some of the benefits to the client as well as the agency that were identified had to do with things like efficiency, time to connect, reducing a time to connection, reducing service duplication, and the higher enrollment in services if we knew there was more clients available. The group agreed that though there's some agencies in competition for clients, that there was more than enough vulnerable older adults in need in the community to go around. We also identified many circumstances in which data sharing would be useful beyond just what we had originally built into our current protocol. The round 2 discussions focused on the barriers and solutions, and we did give them homework before they came back next month for the second round to think about solutions to any of the barriers they were going to bring up. And so the three main foci of these meetings were these big picture barriers to implementing a truly integrated system of delivery. So any sort of programmatic policy regulation issues that may be holding us back. We also talked about the data, exactly how detailed information do we think we need to share and why. And then lastly, the process. How are you going to use that data? How do you want to access it? And how do you want the communication sharing to work? And so the answer to the data question was really interesting because ever since the beginning of the project, the idea has always been, well, all of the data. Like, we all need access to all of the data. And when we finally circled back around to was really, that's not true. We need access to limited information, and most of it has to do with what services are they and are they not connected to the clients that come into the different agency doors. And so we kind of came up with this concept or idea of a community health record. And so I realize we're speaking ideals here, but so the general ideal would be that members of the community would have a record for their in-home community-based service connections, and that this record could be accessible to any in-home community-based service provider, regardless of sector, and I am lumping law enforcement in there with in-home community-based service provider, as long as we were all within the right consents and right business agreements, that this should be something that should be available to all the different agencies. And this is just kind of a mock-up I have of what we talked about it could look like, and that we would, because like I said, we ended up deciding that really the most important information that needed to be shared was simply who are they connected to and who are they not connected to. So we talked about having domains of different service needs, healthcare, personal care, so we knew who was their main provider and that they were connected to someone. So, for example, in this fake patient we made, we knew they were connected to primary care through the federally qualified health center. We knew the AAA was had them connected to housekeeping services. We knew they were connected to Meals on Wheels. But we also know what they aren't connected to. They're not getting any housing assistance. They're not getting any social support assistance. We also talked about a need for some limited case progress notes, mostly having to do with sort of logistical and pragmatic things. So, if the older adult can't hear, it's not very mobile, how do you contact them? Give them time to answer the door. They have multiple chronic conditions, and we have a referral out for something when for voucher for medications, that problem's in progress, who you can contact for full histories on various things, but not actually putting the full history in there because that really is not needed if you're out in the field, or, as an EMS provider showing up to someone's house. The example we got from our fire chief was, it'd be nice to know, just have a quick glance of who this person is, knowing what they're connected to, because while I'm in here doing my environmental scan, I can make a mental note that it looks like Meals on Wheels hasn't been here in quite some time, but that chart said that they were connected. I can do a follow-up and ask them what the deal is. And so that's really what the goal is. We learned with the data sharing. It's not just about one of the things we learned was not just about having data at the time of enrollment, it's the ability to also keep an eye on and to help out the other partners when services might not being delivered that you think they are. And so that brings us to what we think might be the process for the future, wherein we have, the slide color changed a little, but where you have providers down here who interact with the older adult and put things into community service record. And this community service record is then actually managed through what we've been calling a service concierge, where the service concierge does the behind-the-scenes things. And we've learned that our program intake coordinator for our evaluation does a whole lot of things behind the scenes that I don't know that anyone knew she had these many steps, to checking databases, to figuring out what services they are connected to, aren't connected to, could be connected to, and those sorts of things. And so the service concierge would do this client contact, get all that behind-the-scenes things done for the providers who are out in the community, taking some of that service enrollment burden off of them and making sure that the referrals they get are the right referrals, appropriate referrals, referrals for slots they have open in programs. And so next we're going to have Fuad tell you a bit about how the work frame and process for that we think might work. Oh, unless he got disconnected. Okay, well, I will keep going, and we'll wait see if I can jump back in. So if you were a provider, you could be EMS, Meals on Wheels, pick your law enforcement, pick any example in your head. And so if you were to interact under this, what we think might be the next step model, if you interact with an older adult, I think I have a little arrow here. So if we interact with this older adult, and you think that they might have a need for future service connections, so ideally with our community health record system, you'd be able to search to see if they're an existing client. And so this might be before you even go into the home. And if that client exists, you'd be able to see that limited information available to see who they're connected to and some basic background case information. From there, it's simple. Everybody wanted simple, and simple. We agree that keeping it simple is the best option. And so you just got three options. Either you're going to update the service record, you're going to request for more information from one of the partners, or you're going to create a new service request. So it might be that you're updating the services, a note about the services you're providing. Maybe they're no longer a client, or you're requesting more information, so you see they are connected to who their primary care provider is, and you have some sort of question that's pertinent to your enrollment in their services. You'd be able to do this through the secure platform. And then lastly, you may see when you're in there for some other reason that they're having troubles with preparing meals for themselves, and you think a Meals on Wheels referral might be helpful for them. You can go in and put that in. If they aren't a client, you can still do that once we get that client's name entered in with some basic background information. But the idea is we didn't want community providers to be doing a lot of this input. We've learned that, not surprisingly, nobody wants to do the data input. And so that's part of what our service concierge would do. So one feature we don't have, but what we would like to be in there, is that when you are out in the community and you see someone and you want to make a request, we'd like to take some of that not having to know what services are available, who's providing them, take that burden off the person making the request. We want to encourage referrals. We don't want to making that encouragement to also entail then 15 minutes worth of work and Googling and trying to figure out and remember who does what. And so we'd like for them to be able to search by services by keywords and through a computer decision support system that it can help connect or help find that provider or that service connection that that person's looking for, so they don't have so many steps, that we can automate that process for them. And once they say, oh yeah, I think that's who I wanted senior services, they do Meals on Wheels, they could hit submit and put it into the system. Or more importantly, oh yes, senior services is the one who delivers Meals on Wheels to that zip code. I'm going to hit submit and put that into the system. So the service concierge is the new role, I guess service role we've been thinking of for this model. And so once that all goes in, they're really kind of concierging the referrals. So they're double checking that yes, senior services does really deliver, to that zip code. Yes, they meet these other criteria. Or yes, this agency isn't already full. They don't need to go to one that has slots open. And so that's what all these blue boxes in the middle are. It's making sure that it is the right referral to the right person for the right reason, and if not, is there a better referral that's available? And this is done, we think, ideally in contact with the client, working with the client, and getting that extra information they need to know about kind of finishing this referral process. Also allows for the opportunity to learn what their goals and wishes are, how we could be bringing joy to their life, what other connections might also be need to be made. So basically, this is just our workflow of how we think responders would get notified about getting the referral, which is, I guess, not as interesting to talk through, but other than we would have some sort of automated email process where they can log right in, respond yes, no, update as they need to. So I think we've hit our 25-minute mark, so let me stop now so we can answer any questions.
All right, thanks so much. We've got Mariana Chilton's agreed to do some commentary on today's presentation. Mariana is a professor in the Dornsife School of Public Health at Drexel University. She's also the director of the Center for Hunger-Free Communities. So Mariana, would you like to provide some commentary?
Yes, I would.
Thank you.
Thank you so much. Can you hear me? I'm off of mute, right?
You're good.
Okay, great. So I'm delighted to be able to give some commentary on this presentation and on your work so far. It's really quite phenomenal to see how you're developing really a coordinated care system and referral network that could be a model for many of us across the country who are really working on much broader issues, looking at the social determinants for screening and referral. I know that in the city of Philadelphia, we're trying to figure out how we can have a coordinated screening and referral system for food insecurity and housing insecurity. And it's just amazing the number of collaborators and organizations that you've been able to bring together and who are willing to share data. So I think there's a lot of value added in what you're doing. Not just for the elders in the communities of Battle Creek, but really across the country. It could serve as a model for many types of issues in many populations across the country. So it's very exciting, and I think that there's a lot that we can learn also from the data sharing, the data use agreements that you've developed, and how you've been able to, and I know that HIPAA is always a challenge, and I think talking about that type of challenge is important, but it's quite wonderful that you're developing a model for where multiple agencies can tune into the same data system and be able to share and refer. I was also impressed with the diversity of the organizations involved, and I think that the real challenges that you all talked about in terms of the evaluation, this is a phenomenal type of intervention. It really is systems change at its best, but how do you really evaluate that is always a challenge, and I know that this trying to get beyond the HIPAA experience might be an insurmountable challenge, and I'm sure that there may be some other ways that this can be evaluated, certainly by bringing in the experiences and voices of the end user, the seniors themselves, and potentially their families. So, as you hit those challenges, and I know you may not be able to get into the medical record, but you may be able to do some qualitative analysis at the end, as just to get some feedback from the providers and the users themselves. I have a couple of questions, and then and I don't want to capitalize on the questions because I know there are a number of people on the call who may have other questions. But I have 3 areas of questions that I was hoping that you could address. The first area is could you describe a little bit more about the demographics and characteristics? The second set of questions has to do with the types of collaborations that you have involved, and the third is about trauma itself and behavioral health needs of these particular seniors and their families. So I'll start in with the demographics. Could you describe a little bit more about what are the types of communities that these seniors and elders are coming from? What are the poverty rates, the housing conditions, the racial and ethnic makeup of in the community, and also the people that you're serving? And I know that there's a band of the Potawatomi in Calhoun County. Have you been engaging with that tribal group? Tell us a little bit more about the characteristics of the people you're serving or hope to serve.
Hi. So for your question about the Potawatomi Tribe, directly in this project at the moment, no. Our other partner, Elder Law of Michigan, has been working with them on elder abuse prevention issues and this sort of, frankly, and just social determinants for older adults with the referral systems, and that they have been starting a relationship, and I know they've got some plans to do that. I have to pull up my slide for demographics that we cut, so if you give me a second for that. I can tell you, though, it's not surprising that even though, I guess on the one hand we're thinking about social determinants, when it's older adults, people may have a nice, very nice house that's worth quite a bit of money, but now that they've, depleted their bank accounts, taking care of care issues, housing is, the type of house they live in is no longer necessarily an accurate measure, nor is there what their previous job was of what their current financial status is. People have to quit jobs to be caregivers for their, spouses and then have no money when they're older adults. We have lots of, Medicaid downsizing. We are, though, this is mostly who ends up being referred to the program are a large number of Medicaid-eligible older adults. There are some dual eligibles, partially because not already being in a case management program is one of the exclusion criteria. And so some of the private insurance companies down there have case management programs, so we just don't, they don't end up getting into the program for that reason. There's also a good number of people who are kind of, I guess we've been calling them the gap folks, although there's probably a better word for that. But the folks who have too much to qualify but not enough to actually meet their needs. And so I can't really say enough wonderful things about the AAA down there and how forward-thinking and proactive they are. But they were able to get money from the senior millage to have a short-term emergency fund that actually is now, I guess, one of the services you could say that's being offered. Because with that money, they're able to do those short-term emergency things for the folks who aren't, resource impoverished enough to be Medicaid eligible, but don't really have enough to provide for themselves.
Thanks. And just a quick question: what really triggers a referral? Do they have to have evidence of abuse, or is it just really sort of a broader social determinants type of thing?
No, we were aiming for this to be primary prevention. Though, what happens when you get a bunch of older adults we're learning who have all these unmet social and health needs is that once you start digging, oh, by the way, there's something abusive or neglectful that's been going on. But no, what triggers a referral is that one of the providers thinks they could benefit from a connection to senior resources or community resources.
Thanks.
So,
Thanks for clarifying.
Yes, yeah.
So more on to the collaborations. I thought it was so interesting that there was some indication that there might be competition for clients, and at the same time there's a shared decision-making process. Does the competition for clients, do you think, get in the way of collaboration? What is that competition, and can you describe a little bit more of the shared decision-making? What are the processes for that?
Sure. So the competition, it actually did come up in this implementation, but then we were thinking about how do we keep scaling this up, and it did come up. So we decided, as I mentioned, there's just enough vulnerable older adults in need that everyone can have all their client slots filled, and there still would be an underserved population. And so this community is just really proactive about working together, and so it did come up. So if you're not familiar with PACE and Waiver, those are two different programs for getting in-home services for older adults, where Medicaid Waiver is one, and then the PACE program is the Program of All-Inclusive Care for the Elderly, and that is Medicare, Medicaid, or private pay. And they're similar in regards to the provide in-home services. They're a little different in how they get delivered, but they are, I guess, similar enough that you could say those two agencies are in, hypothetically competition for slots. But as it came up, our PACE program got added into the model for the reason that we ended up, they saw a reduction in their client numbers because people were being sent to C3RT instead. And so we just simply were like, oh, sure, you know what, we can add you to our model. We're happy to have more resources available because you also can take broader clients with the differing insurances, whereas the Medicaid waiver program is a Medicaid waiver. And so that was a really good example, but it's also because those agencies know each other and they have good relationships, and the AAA is really a pillar in the community that's respected. And frankly, they're the reason why we have such a diverse number of groups who showed up to the those forums, is because the AAA asked, so people will come. Yeah. Moving forward, we've kind of talked about with the handling competition. You know, right now the intake's done at the AAA, but we've agreed that maybe that's not the best moving forward. If it is going to be, you know, competition or worries about that, we've talked about putting it in like a neutral third party who does this service concierge role. That way someone who's actively providing services is not also the one finishing the referrals. But that's something we're still in our last round of discussions are kind of drive down on options of what that might be. And what it might work out in Battle Creek is probably not going to be the answer for every community.
One thing that might be good as you work forward, and you may already have them, is a set of shared principles and sort of decision-making flow. I think that would be really helpful for all of us who are trying to do these kinds of things to learn about that shared decision-making. My last question on the collaboration piece is, how are the elders themselves invited to participate? What about their family as a support system? And also, of course, I'm thinking about the abuse factor. How are you working to reduce perpetration? I know it's about housing and food and many other behavioral health services, but I'm sort of interested in about where and knowing that it's often the family itself. Can you describe a little bit how you are working with the seniors and their families?
Yeah, so our intake coordinator, she's a community health worker, and I really can't say enough about her. She's been working with older adults and families for years now, and she's just really very skilled. And so when she does this intake, it's all about the older adult. This is her line, which I love and I stole, and I teach it to my nursing students in my public health class. Her line is the line of, I'm here to bring joy to your life and reduce your burden and worries. That's all her. And so she really does a very person-centered conversation, and if they have family members that are there who want to be involved, that the older one wants involved, I know she works to include them. She also, when family does need to be involved for reasons like cognitive capacity problems, she does get family members involved, and she works to balance upholding the older adults' independence and their right to make their own decisions. She always fights for them that to be what we follow to the extent that it can be, and to the extent that we can implement the things they want while helping to work with family concerns. I know that one of our very first clients, she ended up enrolling 2 members in the household, and there were other family members involved that she worked with in problem solving all of their needs together. As far as the perpetration, that first one of our first clients, there was an abuse situation going on between the two older adults in the home, and both were clients who got enrolled into the program model. It takes a lot of, I guess, tact and grace and communication, experience communicating with older adults and their families, I think, to handle that. But I'm going to put a little note that we put some more specific instructions on how she does this in our best practice guide.
Okay. I was asking a little bit more about not just about the senior or the elder and the families as end users, but as advisors to the whole process that you're doing, being a part of that evaluation, guiding your decision making, having some say in who is involved in terms of providing services.
Yeah, so they do get, nothing that they get enrolled in is done without them wanting it done. So they pick the priorities. They can say yes or no to services. They also can say yes or no to who the data gets shared with. Part of the uniform consent form, we ask for the ability to share with everyone for the reason you may end up needing services from someone, but if they say, no, absolutely not, don't share it with agency X, then we don't. Obviously, we follow their consent form. So they have control over all of that. And in the work building up to it, older adults, some of the clients who went through were involved, and actually how the agency got that short-term emergency fund money was one of the former clients went to the senior millage and testified for it. In this evaluation, we do have actually qualitative interviews built in to do follow-up about what they thought the process was, how it worked for them, and how we might fix it based on any unmet needs or concerns the clients had, including family members if family members were involved in their case as well.
Well, thanks very much for answering the questions. We only have a few minutes left. I'm sure there's other people on the line that have some ideas and questions. One other thing I would, we can talk a little bit more offline about integrating a trauma-informed approach to those service provisions. My guess is that many of the organizations around the table working with you have a trauma-informed approach. But since it's an abuse prevention type of program, being sort of explicit about how this might be a trauma-informed way of providing wraparound services could be really exciting for many of us. But I wanted to thank you very much, and I don't know if you want to be able to build in time for questions from others, but I hope we can.
Thank you so much. Looks like we've reached the actual end of our presentation today. Well,
if you have questions, you're welcome to email us.
Great. This is a list of our upcoming presentations. Thank you for attending today's webinar. If you have any questions, please feel free to contact the email address below. Thank you.